All right. Hello, everyone. Welcome. Welcome to the role of the family in research and care. My name is Zachary Messer, research manager from New York Medical College, Boston Children's Health Physicians, and Westchester Medical Center. Joining me, all of my panelists and co-host Lila. If you guys wanted to introduce yourself, you can go down the line.
Hi, everybody. I'm Lila. I'm from Chalk Children's in Orange County. I'm a research coordinator.
Hi, I'm Michelle Mann. I'm from Baylor, Texas Children's in Houston, and I am a pediatric pulmonologist.
Hi, I'm Renee. I'm just a fiance of somebody who has CF.
Not just.
Hi, I'm Cambry White, and I have a 4-year-old son with CF.
My name is Rachel Stonecipher. I'm with National Jewish Health in Denver, Colorado, and we are an adult clinic, and I'm the licensed clinical social worker.
Hi, I'm Meredith Gosson. I'm from Cohen's Pediatric Children's Center, and I'm also a licensed clinical social worker.
Thank you. And then while we were up here, we actually started thinking that we kind of want to know who all of you are. So by show of hands, how many social workers do we have in the crowd? Smattering. How many families of or patients or people with CF or families of people with CF? Okay, so there's right there. All right. So, clinicians. Okay, all right, decent. And finally, my people, researchers, clinical researchers. Yeah, that's right. All right. So first, we're going to turn it over to Lila. She's going to kind of give us a little brief introduction, and then we'll get going with the rest.
All right. Thank you guys for coming. So again, just so you can see everybody's names. And we have 2 disclosures here. Cambry works for the CF Foundation, and Dr. Mann is a PEP workshop facilitator. And today's objective is about the role of families in cystic fibrosis care and research. So great topic. We're all here for this conference for people with cystic fibrosis, and it's amazing to see what everybody does. But we really wanted to focus this session on the family members and the loved ones of people with cystic fibrosis. So just exploring the different dynamics that's all about. And to start that off, what is a family? It's hard to define it as one single thing. So the definition is any combination of 2 or more people who are bound by many things. But there's a birth family that you're born into, and then there's also a chosen family of people that you love and that love you. So a lot of different people who can be considered family, and those people tend to assume responsibility of the physical and mental well-being of their loved ones. So there's a big range of what we call family. And then how families support throughout life with cystic fibrosis. I think that's very important, obviously, why we're doing this whole lunch and learn session. But infancy to adolescence is a critical time in people's lives where they require a lot of hands-on help, and they have daily medication and therapy regimens, treatment schedules. They need to be driven to their clinic visits, monitoring for symptoms, and as a team of providers, we dedicate ourselves to listening to those family members because they're the experts on the patients. And then adulthood is different, but still requires a lot of support, and so it's not as hands-on, but especially during acute illnesses, it gets hands-on as well. So, great. I'll pass it back to Zach.
So there is some research on why family support's important and what that kind of brings to the life of somebody living with CF. If you higher perceived support for a person with CF can predict fewer mental health problems, a lower treatment burden, higher functioning in their life in general, and even lower eating disturbances and GI symptoms. One study found that generally a 10% increase in a person with CF's perceived support from their family and support system can lead to a 5% improvement in their mental health and a 2.5% improvement in their physical health, so affecting both mind and body. And to kind of crystallize all that, we have this very advanced diagram that we definitely didn't just make in PowerPoint in about 5 minutes. So CF adds a lot of burden to both the patients living with it and the families who support them, signified here by the weight on one side of the scale. And the caregiver burden is balanced on the other side as well, kind of back and forth. The more support the caregivers give, the higher their burden, the better for the CF patient. It's a very complicated system. But the support that can be given to these people with CF it kind of acts as like a ballast to hold this scale up. So that's our quick overview. And is this your slide? Is this where your slides start? Or? That's still us, okay. Very well practiced up here and well rehearsed. We want to also talk about how healthcare providers and research teams and care teams can support not only their patients, but also their patient support system. So they can actively listen to the family's unique understanding of the patient's needs, which sometimes can surpass the patient's understanding itself, as you'll hear in some of the coming talks. They can kind of recognize burnout before it happens and encourage people with CF to kind of take care of themselves a little bit more, and maybe some of the needs that are not often addressed by the traditional medical advice. You can include family and friends in discussions and care decisions in a very active and meaningful way. And we can also improve all of that communication with PEP skills, which maybe a lot of you are familiar with, but if not, we're going to have a presentation on that in just a moment. And with that, I will turn it over to Dr. May.
Okay, thank you. Yes, so as Lila had mentioned, I am a PEP facilitator. So what is PEP? PEP is a relationship-centered communication course. I'm curious how many of you have had this training with your CF team? Show of hands. Oh, great. A lot of people. Yay. So you guys are familiar with this. Basically, this is a course that several of facilitators, we travel around to different CF centers across the country and give this training. Facilitators include all different subspecialists, as you can see here. The mission of PEP is really to strengthen partnerships between people with CF, their families, and care teams in order to improve care and quality of life. So for me, it's more than a training program. It's become a community that's grown under the leadership of Cindy George. This network of people are passionate about ensuring that CF care really respects the family's role and experience and priorities. And we know that, in doing this, creating this more collaborative care, grounded in understanding how CF fits into people's specific lives, we can identify barriers and move more towards better outcomes and better quality of life. So personally, being a part of this group has been a highlight of my role in the CF community. And what stands out the most to me is just some of these skills to help you create this intentional space so that you can really hear the family's stories and help you understand how care decisions that you make really play out and how we can support our families in order to allow those plans that we make to actually happen. So how PEP works is that, one second. So there we go. We train teams on these 3 evidence-based core skills. And these are the skills really establishing trust, creating an open dialogue, setting goals by partnering. And within these core skills, there are these micro skill sets, and these are practical tools for daily interactions. Okay, and so this slide really shows how we teach teams to restructure the clinic visits to incorporate some of these intentional acts and how we can practice these skills and make these interactions with patients and families more meaningful. This last slide is a new program that we had developed over the past year with the CF Foundation. This is specifically for research teams and research coordinators. The intention of this is really taking a step forward and mastering those PEP skills to help research teams, answer some of these tough questions, address these difficult barriers to research that people may come across, and then questions that they have when enrolling in trials that can be more risky. Lila got to be a part of this group, and then Mael over there as well too. So it really got to illustrate how we could use these skills into improving the relations with our families and our patients that are participating in research. So with this, I'm going to pass it off to Renee, who is a partner of someone with CF.
Hello, I'm Renee. I'm a fiance of somebody with CF. We've been together for almost 5 years. We have 2 cute dogs together. We're stagehands together. And we got engaged at the New York Renaissance Fair. But that's not why we're here. Why we're here is Nick's participated in 4 different research studies since we've been together, and the most notable one is he was the first person in the US to do the mRNA gene therapy through RECODE. And I guess I could just kind of paint a picture of what that was like when we got asked to do that. And I say we because he always makes sure that I'm okay with him doing the research studies, but most of the times I say yes and what's the next steps. When I heard that this study, he was going to be in the hospital for an overnight, so 2 days, 1 night, I was kind of like, I think I want to be there for that one. I don't think we should just have you handle this on your own. We weren't told at that time that he was going to be the first person to do it either. We were just told that it's a new, research study. Let's just see what it's like. So when we get there, we were told by one of his doctors that I shouldn't be involved because I'm just his partner. He's 28 years old. He doesn't really need anybody. He could handle it on his own. But I said, no, I'm from New Jersey, by the way, so I know how to advocate for myself. I was like, no, I'm going to be there. The way our work schedule is lined up too, it was going to be the day before Christmas Eve, and he would be released on Christmas Eve, and then the next treatment would be the day before New Year's Eve, and then New Year's Eve. So of course I was going to be there because I knew then afterward he was going to be interacting with family, and I wanted to know next steps of treatment if he needed to go to the holiday parties and stuff that we've planned. But at the same time they were telling us, no, you can't go. We don't know if you're going to be able to go. So on the day before Christmas Eve, we showed up to the hospital and I go, I'll just sleep in the car overnight if they don't let me stay. And I'm just going to be there. Then finally, when we were there, we met his doctors and they were like, okay, cool. We don't know how involved you can be. And then after the treatments and stuff, obviously the doctor's not in the room the whole time. And Nick, he's awesome, but he doesn't like to advocate for himself. He's very chill. He's like, oh, I'm fine. Everything's fine. So there were many times where I'd bring up to the doctors, hey, he's actually experiencing this. And hey, they had to do I think it was 6 different vials of blood, I think 4 times while he was there, 2 the first day and 2 the second. And by the 4th one, he wasn't really feeling it. And I was able to step up and be like, he really wants to do this. Please give him a break. He's struggling. So I was there to be an advocate for him. What was really interesting too is after he got sent home from the first treatment, he was still experiencing symptoms. And, I was able to take care of him because I knew what to look out for, what to make sure to tell the doctors about. After the second time he was in the hospital, he got used to the treatments a little bit more. Then he was able to do them at home, or not at home. They would do the treatment and then send him home. So then instead of overnight watch, it was just he was reporting to his research team what was happening. And I was the person who was going to watch him. So I was so glad that I advocated for myself to be there for the first couple of times. So I knew what to watch out for. It was actually good that I was there, and his doctors ended up really enjoying that I was there because one of the big symptoms of the gene mutation therapy was high fevers overnight. And I, since I've been with him for so long, I know when he has a fever and when he doesn't and when he's sleeping. His thing is he hallucinates at night and says random things and sleep talks. So we would go to the doctor's appointment afterward and they'd be like, oh, did you, how'd you sleep? Did you have a fever? And he'd be like, yeah, I slept fine. And I'd be like, no, he hallucinated all night. So clearly he had a high fever, but he doesn't know that because he was sleeping. His mom is in the medical field of sorts too, and she had a pulse meter. So I was able to, at night when he's hallucinating, I'm making sure that he doesn't have a crazy high fever that I need to take him to the hospital. So I was able to keep track of more statistics at home as well. So then I was able to share that with his research team. Another pro of me being there was being able to explain to family and friends why he wasn't feeling well. And, you know, his parents are very good at not like being involved anymore because he is 29 years old. They don't want to like, you know, baby him his whole life. But obviously his mom was very worried about being the first person in the US to do this. So then I was kind of able to like be the liaison because he's kind of like, no, mom, I'm fine. Everything's fine. Everything's going great. When I could be like, okay, this is what you need to look out for when I'm at work and stuff like that. So one of the main things why I was excited to speak here is because I think that everybody should be able to have a support person. If a 21-year-old who's away at college wants to have their roommate as their support person, they should be like the care teams, the research teams, the hospitals, whoever's involved should just be like, yes, what's their name? Let me have like their license or whatever information they need, and let's have them be involved. There should be no pushback. I mean, we're domestic partners for insurance reasons because that's always fun. So that was able to get me like a step ahead being in there. But because we weren't married, I wasn't supposed to be involved. So I think anybody, if they want a support person with them, they should be able to be involved to whatever aspect they want to. And from like the ground starting, like once a research person comes up and says, hey, we want to do this study, they should be able to involve their support person no matter what they want. So yeah, thanks.
Hi, everyone. My name is Cambry Vasquez-White, and my disclosures include that I am an employee of the Cystic Fibrosis Foundation, and these experiences and opinions that I'm going to share with you today are my own as a mom to someone with CF. It was November 2022, and my son Roland, who has cystic fibrosis, and myself were at CF Clinic when Roland, who was 1 at the time, vomited all of his Kate Farm supplement he had just had right in front of our pediatric GI. I sat there on edge explaining to the GI how common this was. Roland already had an endoscopy, laryngoscopy, bronchoscopy, pH probe study, and a delayed gastric emptying test where we discovered our 1-year-old had severe reflux and gastroparesis. Despite medications to lessen the symptoms, Roland was still vomiting weekly, sometimes daily. Roland had annual labs that day, and when we received his results, his lipase and amylase levels were very high, indicating an issue with his pancreas. We did another blood draw, and the lipase results were even higher, and my worst fears came true. Roland's first hospitalization happened at just 1 year old due to complications of cystic fibrosis. Roland was admitted for presumed pancreatitis. Becoming a first-time mom has its challenges, but I never imagined that my son would have to be sedated for multiple procedures at 1 year old, pricked and prodded by needles, and admitted due to complications of a progressive genetic disease. Even so, nothing could compare to the dark reality at that time that Roland's rare CF variants, H609R and 2184 insertion A, were not eligible for a modulator. In fact, the combination of a hospitalization at 1 year old and knowing at that time Roland wasn't eligible for a modulator resulted in a feeling of heaviness and hopelessness too, only exacerbated by the fact that Trikafta was expected to become approved for the 2 to 5 age group in a few months, and the reality that Roland could potentially be left behind. That heaviness was all-encompassing, and it took all of my emotional energy to push through this heaviness and be Roland's #1 advocate in partnership with our CF clinic. I want to share with you today, from a parent perspective, why it's so important to empower the families you work with, to provide resources and information to the families so they can make the best choices with the information they have, and why developing rapport is the foundation towards a partnership between families and patients and the CF care team. But first, I need to start from the beginning to provide some important context of our family's experience with my son's rare CF variants. Roland was born on June 18th, 2021, 2 days after his due date, at 8 pounds, 2 ounces, and in the 40th percentile for weight. Those first 2 months, we were blissfully unaware anything could be wrong. At 2 months, Roland's weight was at the 15th percentile, followed by the 3rd percentile at 3 months, when we knew something was wrong. Our pediatrician still wasn't too concerned, but agreed that he should be referred to a pediatric gastroenterologist. The GI provided additional interventions, such as adding formula to my breast milk and starting him on omeprazole to treat what we believed was silent reflux, and while he was gaining weight, it still wasn't enough. This led to a stool sample, blood work, and a sweat test, which ultimately led to a CF diagnosis. It turns out that I had a false negative carrier screening and Roland had a false negative CF newborn screening due to 2 rare CF variants that were not, and are still not, on California's CF newborn screening panel. One of these variants is only found in South American, mostly Ecuadorian populations, and a study conducted in Ecuador shows that the frequency of H609R is similar to F508del in Ecuador. A public health program failing my son led to distrust not only of public health programs, but of healthcare professionals as well. During these moments that I've highlighted, a diagnosis at 6 months and a hospitalization at 1 year old, I felt lonely, angry, and an odd sense of betrayal. But among those moments of despair were flashes of hope. Shortly after my son's diagnosis, we met with our genetic counselor who shared more information about Roland's CF variants and suggested that we enroll Roland in a serotyping study where we took a nasal swab and his nasal cells were grown in a lab to test against the eligible modulators. While one of his CF variants is a frameshift variant and is unable to benefit from modulators, his other CF variant, H609R, is a missense variant, and there was reason to believe it could potentially respond to Trikafta. We, in partnership with our CF care team, were hopeful that data from the serotyping study could help provide a case for Roland to access Trikafta when he turned 2. Unfortunately, the results were not ideal. Trikafta provided a small bump from his baseline function, but unfortunately not enough to utilize in a petition to the insurance company to access Trikafta off-label. The results were heartbreaking for me. Perhaps my worst fears had come true, that maybe that was it. Maybe modulator access wasn't realistic for my son. Thankfully, our CF care team still decided to pursue a petition with our insurance company, citing the very limited research that exists on his CF variant and indicating that Trikafta could potentially save my son's pancreas. My son is pancreatic sufficient, but that hospitalization at 1 year old gave our care team reason to potentially believe that perhaps this was a sign of him going pancreatic insufficient. Thankfully, after an initial denial, the insurance appeal worked, and at 2 years and 3 months old, Roland had access to Trikafta off-label. When Roland started on Trikafta, the nightly vomiting stopped, and his lipase and amylase levels went back to normal levels almost immediately. Anecdotally, I do believe this was due to Trikafta. I do not take for granted that Roland may have received off-label access due to a combination of great health insurance and a CF care center, and specifically our genetic counselor who advocated that this is in Roland's best interest. Despite my gratitude, I had some fears. We needed an authorization every 6 months. What happens if our insurance company decides not to renew the authorization one of these days? We were fearful it could be taken away from us at any time due to both of his CF variants not being eligible for Trikafta. But then something unexpected happened. In December of 2024, it was announced that a new modulator, Aleptrek, came out, and it's the first and still currently the only modulator approved for Roland's CF variant. I happened to stumble upon the Cystic Fibrosis Foundation's clinical trial navigator, which indicated that there is an Aleptrek clinical trial happening at a local clinic near our house. I reached out to Lila, who is our coordinator, to inquire about the study. I will not lie, my son's only 4, and I was hesitant to enroll him in this trial because he is so young. I had initially declined, but after speaking to Lila and the PI of the project and weighing the pros and cons with my husband, we ultimately chose to enroll my son in the Aleptrek clinical trial for a few reasons. Number 1, it is the only modulator that is eligible for my son, and we believe he could potentially benefit from Aleptrek. And 2, the generations before us who have enrolled in clinical trials have paved the way for my son's increased life expectancy and quality of life. So we have chosen to pay it forward. We know this trial could impact others in the future. The people that knew me when we first got Roland's CF diagnosis know that the CF diagnosis simultaneously broke me and lit a fire in me. Becoming a mom changed everything for me, and I have been okay with the discomfort of advocating for Roland, being persistent about the CF care I believe he deserves, and speaking to bring awareness about Roland's situation with rare CF variants. That distrust that I had experienced from providers not actually thinking my son had CF, at least initially, or newborn screening failing my son, has been resolved because of the people that I've met along the way. From the newborn screening steering committee I found myself sitting on shortly after my son's diagnosis to our CF care team, I have the privilege to see all of you sitting in this room, clinicians and researchers who have dedicated their careers to ensuring that people like my son have the best and longest life that they can possibly have. If it weren't for this rapport that has been developed over the last few years, I'm not sure I would have wanted to enroll my son in a clinical trial. So my takeaway is this: the CF care team has the ability to empower patients and families, or families with a connection to CF. You all have the ability to provide a space to create a partnership with patients and families you work with, not a power imbalance. I believe empowering patients and families to learn about the science that's improving cystic fibrosis care and providing resources to engage families, such as information about programs like Community Voice or the CF Trial Navigator, can be very impactful for families and patients with CF. Cystic fibrosis will always be overwhelming. For me as a mom, it involves balancing work full-time with 1-hour treatments twice a day, phone calls to insurance companies, transportation logistics to get to clinical trials, and CF care appointments, and the difficult task of evaluating benefits and risks in many situations for my son. However, I find myself more confident in managing my son's CF and making decisions when I have the support of my CF care team that makes space for questions and provides me with all the information so I can make the best decision I can. Thank you.
Thank you. So that brings us to the audience participation part of our show. You can ask questions either through the app, and they'll show up here, and Lila and I can pose them to the group. There's also microphones located in the room that you feel free to walk up and ask questions to. If you don't ask any questions, there's going to be a very short session. So to get us started with, for Renee and Cambry, but also anybody, feel free to weigh in. What are the most significant ways that your life has changed pre and post having a person with CF come into your life?
Okay, I'm gonna move this a little closer. So before I met Nick, I didn't know much about CF. Barely at all. And I remember him telling me and him then going, don't research anything because I'm not like that. And then also don't watch the movie 5 Feet Apart without me. I want to watch it with you. So it was actually really nice. We watched the movie together. He would pause it and explain his condition versus other people with CF and everything like that. So I didn't really know anything until he taught me. And then of course I didn't listen to him and I Googled just to see what else was out there. But since being with him for 5 years, it's kind of just reminding him to do his care all the time. When we first were together, I didn't want to be the nag, but now I like being the nag because I obviously want him to live forever because he's my partner. The other thing too is just kind of teaching people about CF because a lot of people in the communities that I'm in also didn't know about CF. So explaining the research studies that he does and why they're super important. And then just if he's coughing a lot and people are giving him looks, it's hey, he's got a lung disease. Can you stop looking at him that way? And then explaining about what CF is. And then I think the biggest is people on the street will also look at him and I'll just say things. So, I'm a big advocate for just, making sure everybody feels comfortable in their own skin and making sure people understand all the different types of people there are in the world. So yeah, taking care of him a little bit. He takes care of himself the most, but mostly just teaching people about what CF is.
Yeah, so I think just becoming a mom is hard in general. I think a lot of people can relate. But I think when we got the CF diagnosis, just I think the logistics have been really challenging, especially going back to work, just trying to find a way to get it all in. And there's just way more that goes into our daily life than I think people realize. But I think the hardest thing, or the thing that's really changed the most, is that I talked in my speech a little bit about like evaluating the risks and benefits. And I think that happens way more frequently than I would have thought. So for example, if there's a pool party, but there's a jacuzzi there, we have to that one's pretty obvious. We will not let him go in a jacuzzi. But even like pools, like figuring out is it okay to do an indoor pool, or, just little minor things. He's in TK right now and he just loves to run and roll in the dirt. And so it's okay, well, what do we need to share with the teachers about mud? So it's just, there's all these little things that I think have just really impacted me in a way that makes it, just challenging. So I would say that's kind of the biggest thing, is just the emotional toll of evaluating the risks and benefits of doing something.
Yeah, that's really interesting that you say that, Cambry. So what do you think we can do as a care team to help you guys and support you through educating people in your loved ones' lives? Can we provide information to your teachers, and what would be helpful?
So I think I'm a big proponent of just providing as much information as you can to the family or the patient, just because I think at the end of the day, it's always going to be overwhelming. And I think it's important for families or patients with CF to have all of the information necessary to make their own decisions. And so I think I know that there are some toolkits you get with educational resources that you can provide to families, and then potentially maybe provide some of those resources to people like me who has a son, and I'm, not sure how to, communicate with the teachers. Having some sort of resource that's provided, or we can talk it out at clinic. I think for me, at least, that would be really helpful. Of course, everyone's different, right? So definitely assess the people you're working with. It just kind of depends on, what they need.
Great. Yeah, and go ahead and ask your question.
I don't know if this is on, but I'm Joe. I'm from Michigan. I have an 8-year-old with CF. I have 2 questions. One's for Cambry. With Roland being 4, what was it like kind of explaining the clinical trial? Hey, this is something new we're doing. Did you explain it, or was it just hey, this is what's next? And for Lila and team, what is it like to kind of do clinical trials for, CF is rare in general, but even for a rare portion of CF, is it? How do you choose that? What is it like to kind of figure out what's next? I know that's probably difficult to do, but what is it like to kind of figure out the next steps? So,
great question.
Yeah. So, he's 4, so he doesn't understand what a clinical trial is, but he understands what a hospital is. He understands doctor's appointments. And so when we decided to enroll him, we said, hey, Roland, you're going to be going to the doctor a lot more. It's going to be a new hospital that you're going to, because the hospital that we are at is different than the hospital where we do clinic. And so he's very outgoing. He loves to meet new people. So I think for us, it actually was pretty easy. And then he kind of just said, okay, yeah. And you know what? I think one thing that's really important is the relationship that Lila and one of the other coordinators has built with Roland, because Roland loves them and they just interact with him and they get down to his level to talk to him. So it makes these visits fun for him. He gets a bunch of toys. So so I wouldn't say I fully explained it to him, but I just kind of prepped him that we will be going to the doctor a lot more. And then now that he has that relationship with Lila, he looks forward to going to his appointments. He asks about her.
He's so cute. Yeah, I think that was really important for me when we started this trial with the younger kids. Is I was I need to have toys for them and stickers at a minimum, but especially, I don't know if you guys are familiar with the multiple breath washout test, but that one's a long time sitting down. And I was explaining that to the parents before we did it. I'm you're going to be sitting, you have to hold him still, he has to breathe normally, and it gets frustrating for everybody involved. But toys help, shows help, and talking to him, giving him breaks. And it's knowing our patients, and I'm sure Zach and Renee can talk more about their gene therapy trials. Those are really complicated in different ways. So I'll let you guys discuss that too.
Yeah, speaking to the second question a bit, I think actually in my experience, the CF trials that we do often run a lot smoother, and participants tend to be more engaged and more knowledgeable than more common things. Like we also do asthma trials, and I think the CFF and the CF community has done a really impressive job of pushing this culture of research and letting people know that these advances don't come out of nowhere, that it's, all these people who are willing to take a chance that bring all this stuff to market and bring these therapies. So actually in CF, I think research it's not easy, but it's more collaborative, whereas in more common diseases and maybe diseases where the burden is not as high, people don't have that pull as much. You're kind of convincing them more that this would really help and this will help other people. In CF, I think that's already established, and then we just kind of say, and here's an opportunity to participate as well.
Yeah, I would just add a little to that. I think that's a really good point, Zach. I don't think there's a lot of diseases where there's such a strong foundation pushing the voice of the person with the disease on helping give input into the clinical trial. So things like Community Voice and that Jerzy Borowitz worked on, and other programs through the foundation of really just making sure that where we put our time and money and research is in alignment with what the families and patients want. So I think that's a strong point.
You got anything on that? No? Okay, cool. Yeah, we've got a few questions that came in. First one is, how do you balance developing independence in our transitioning teens for allowing support? So I think we've got, you can speak on that as a provider, social workers, and family members, everybody. Whoever has something to say, go for it.
So I'm Meredith again. So I'll start. In peds, we actually starting at we've been trying to do it 16 or maybe even younger, starting to do this track form. Actually do it with Sasha, who's the pharmacist in our clinic. Kind of talking to our patients about, okay, mom's out of the room, dad's out of the room, or your support person's out of the room. What are your meds? What are your respiratory treatments? Who's your doctor? Where, what pharmacy? So we try and kind of give them a little bit of agency before they go to college, and they call and they say, wait, what do I have to do? So when we start transitioning them then, but support systems change as they get older. Once they get to college, they have new friends, or they're further from home, so they need someone different than the parent. It's also then helping the parent to understand, they'll be okay. We have to loosen the strings as much as we don't want to, but give them the chance to, they'll call you if they're struggling. So it's really kind of boosting the confidence and ego of both the patient and the parent or the previous support person.
I'll speak on the adult side. We still have 30 and 40-year-olds that come with their parents. And we give the opportunity, being the social worker, and I'm asking really personal questions. I give the option, hey, do you want them to remain in the room or step out of the room? What do you feel comfortable with? We have people that bring friends. It's always fun when they bring a new partner in, and that's to explain and let them ask questions. What's their understanding? Parents are great advocates, and we don't mind, and we allow them as long as the patient is comfortable. And but we also too would like the patient to advocate for themselves and learn that piece as well.
So I wasn't with Nick when he was doing that type of transition from teen to adult, but I did notice that stepping into his life, I noticed that a lot of his friends asked me more, is he doing his treatments? Is he taking his medications more than his parents? Because his parents kind of just trusted him. Of course, he lives with his parents, so they could kind of see it. But I think his strong friend group and having him explain to his friends, all the things that he does. I know he's done his treatments in front of a lot of his friends too. So I think having that social group that was, nagging him and being able to ask his parents and everything that care about him, then pushed him to then do better. There were times that his friend will pull me aside and be like, you need to tell him to do his treatments more. And I'm like, don't worry, I'm working on it. And they're like, let me know if I need to step in and tell him, because I've been telling him for like 10 years. So just like having their friend group involved too during those years, I think is really, because they'll listen to their friends over their parents, I think.
Yeah, great. All right, we're getting a lot of questions in here. Let's see what's next. So,
For Cambry.
the second one?
Yeah.
Yeah. Okay, this one's probably for Cambry, and then social workers too can chime in, and you can too. With the connection to rare mutations, are you able to advocate in California for new screening tools? Also, how are the rare mutations handled in Ecuador?
Those are some great questions. So shortly after my son's diagnosis, I actually applied through this Community Voice email that I got from the CF Foundation to be a part of the Newborn Screening Steering Committee. And so over the last 3 years, I got to learn a lot about newborn screening, and I also got this wonderful opportunity, along with many experts in newborn screening, to author a paper. So that was really cool. And I think that was kind of my first step of like wanting to advocate for various states. And so the recommendations that we published, they're for, just every state. As far as California specifically, I did end up calling the state newborn screening lab person at the time to kind of see, like, offer my help if they ever have any advisory committees. I think at this time I don't know of any, but I think the published recommendations for newborn screening that were published in April 2025 are a great first step. And I went to the QIC, the Quality Improvement Consortium, on Wednesday, and there's been some progress made in some other states, so that's really cool. And then, can you repeat the second question? About
Yes.
Ecuadorian.
It's about how are the rare mutations handled in Ecuador?
So I actually know the answer to this, shockingly, but they don't have newborn screening in Ecuador. And a lot of the panels that they use are from the US. So like I said, a fire was lit in me, and I actually met another mom who has a son with the two same rare mutations as my son, and her whole family's Ecuadorian. And so I really think we like pushed each other to really advocate. I don't know if I could have done it without her. But we ended up talking to some pulmonologists in Ecuador, and what we learned was that they use the panels from the US. There's one that they use, they would send their information to San Diego. And so, but because H609R is so frequent, especially in Quito, which is the capital of Ecuador up in the Andes Mountains, they have to do a separate assay for H609R and add that in addition to the panel. But not every hospital has access. Yeah, so it's really complicated. But yes, I wish they had newborn screening, and I know that there's some people that are at NACFC that are working on establishing that in Ecuador.
Great. All right, we've got another comment/question. So somebody wrote, as a mother of 2 kids with cystic fibrosis, I also think that ongoing education for parents and family is important. Our oldest is 11, and we feel like old pros most of the time, but occasionally new things pop up, like the possibility of mowing the lawn, and someone may have told us that when she was a baby, but we have forgotten. We talked to our providers about checking in on some of these do's and don'ts as the kids get older. So does anybody have comments on that, and you as a provider?
Yeah, I think it's a really great comment because we bombard a lot of education in the beginning with the diagnosis, and then sometimes we forget to review and go over things as children go through different developmental stages. And I think a part of how we can do better with that is really trying to make this space to identify what the priorities of the families are for those visits. And I know we do, some pre-visit screening questions, but then we also say, thanks for filling this out, but I wondered, what other things are on your mind? How are things going? And just really trying to leave that open space and being intentional about what might come up, even if it's not on our agenda. So hopefully that could be how we could help with those questions that come along later that may not necessarily be on our minds.
Yeah, so I'm sure everybody who goes to the doctor knows you leave the doctor and then you're like, oh, I forgot to ask that question, So how do you guys manage that as family members, and what are some strategies from social workers to kind of help remember those things? Obviously writing them down, but how do you decide what's important to you guys during your visits? for family members.
I mean, I don't know if this is rare, but Nick has most of his doctors that he could text and then just ask the question. So like, I don't know, he has like a close relationship with a lot of them. Like, I want to say at least 4 or 5 that he knows he could just text and ask those questions. And then sometimes he just goes to his parents too, because most of the times they'll remember the answer that they were bombarded with when he was a kid. And, you know, his mom wrote a lot of things down and stuff too. But yeah, he just has a really close relationship with his doctors.
So I ask a lot of questions. I think I ask more questions than a lot of family members. So I got to the point where I started writing the questions down ahead of time just so I could just like rapid fire them off to the providers. And then, yeah, if I would forget something, which, you know, would happen, I would email them. Yeah, so.
Question came in. Any advice for bridging the gap between research teams and clinical care teams? We have patients that travel from out of state for just research and they are seen at another institution for routine clinical care. This is becoming a bigger and bigger issue as we move into an age of genetic therapies, and there's many more patients with access to highly effective modulators. The pool of research participants is shrinking, as is the number of sites performing these things. So referrals are becoming much more common. At our site, I know something we've done that's really helped is to kind of use technology to our advantage. We'll set up like a Zoom kind of handoff meeting in a way from the patient's clinical care team to our research team and PI, ideally, and kind of they give us their history, we tell them our experience, we tell them kind of what to expect and how the communication will work back and forth, and that seems to kind of set the tone right. In my experience, most referring sites are less worried actually about the research itself and more worried that you're going to take care of their patient with care and respect. You know, they care about their patients and they don't know who they're sending them off to necessarily. So yeah, I think that kind of handoff helps a lot. I don't know if anyone else.
I can speak on that one too. Actually, a coordinator that I work with is in the room, but she was great and reached out to me to refer one of her patients, and this is new to me, the referral process too. And so we kind of navigated it together. We talked about how we can make it as easy as possible for the patient and the parents, and then we communicate regularly. We have the providers know each other and connect as well. So that's been helpful because if there's like a concern that comes up clinically, and then the research team can address it too. And yeah, just like being aware of what's going on and constant communication. And I have a question for Zach, actually, and Renee can answer too. But so Nick was the first patient on the gene therapy trial, right?
Yes.
What did you say to Nick when you were preparing? Like what? And then what did you hear on your end?
Yeah, that's true. Yeah.
Yeah.
It's like telephone.
Yeah.
So my role was not actually to kind of talk to Nick directly. It was Armando, our senior RC, who couldn't be here for this meeting. He would be kind of the one to talk to Nick. We had a relationship with Nick already because he had done some other studies with us, and so it was, you know, easy. But I will tell you that in the the background there, we talked about Nick for weeks before we approached him in all of our research meetings and all the, like, we're going to talk to him. How are we going to explain this? What are we going to do? Do we have the hospital set up? Blah, 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 blah. And then after like a month of talking about him, we're like, hey, Nick, fancy meeting you here. So, yeah, I mean, you know, part of it was, but part of the reason, not only that he met inclusion criteria, was that we had a relationship with him. We were new to genetic therapy trials as well, so we thought this is a good candidate to kind of get everybody's feet wet with it.
So like I said, he's done a couple studies before the gene study. So a lot of the times he goes, hey, Armando reached out to me when I was at my, normal visit. Because it's almost like, I don't know if this probably isn't common, but when he goes to his like normal CF care visit, Armando will come in and talk to him as well. One, because Nick and Armando are like good friends, but then two, Armando then pitches things to Nick.
That's by design.
Yeah, yeah, exactly.
I do the clinics too.
Yeah. So then he'll just be like, hey, Armando told me about like 3 different, research studies. This is kind of like the timeline of them. This is what's involved. This is like what will be covered. I mean, one thing that we haven't talked about yet is that Nick kind of has like, he doesn't have a normal job. He is an owner operator of his own business. And then we also do stagehand work on the side. So he could create his own schedule. Obviously, he'd have to say no to some work because he has a very physically demanding job and he needs to be able to go to studies. So it's also like, how much would I get paid for this? Because you have to weigh against like, okay, then he can't take like this study. He had to be out of work for almost 2 months, And it was also like in the winter he does snow plowing, and it's like if you're doing this crazy gene mutation study, you can't really be like up for 24 hours shoveling snow and all those types of things. So it was how much time it was going to be, how much money, and then what's involved. And most of the times I'm like, cool, like let me know if you say yes, I'm okay with it. And for this one, it was like, it's kind of new, but you have to like stay in the hospital as well. And that's when I was like, okay, we should find out a little bit more if we're staying in the hospital, like what are the details of it? Like how is it administered? Because most of the times he's been doing like the pill therapies, and this was the first like breathing therapy that I was with him, which is a lot scarier in my opinion. So then it was just like, here are the questions I have, can you ask Armando? And then we learned from there basically. But almost always it's a yes. It's just if those 3 factors of pay, time, and if it's not too invasive, he's okay with it.
Yeah, I think that's something that the sponsors can help with and do better. Obviously, like everybody who's participating in a clinical trial, it's physically demanding and time demanding. And it's like, if they paid more, that would be great. And then like providing transportation, providing reimbursement for transportation and food, and those kind of things can really help facilitate making that easier. Yeah. And then another thing I wanted to add too about how we bridge the gap between research teams and clinical care teams is we rely on the family members, like I rely on Cambry to tell me how her son's feeling and if anything changes. And is like, Cambry, you want to add anything on that? Like what you look out for and how you communicate it to both me and your clinical team?
Okay. Can you say that one more time?
So it's like when you're participating in research at one center and then your regular care is at another center, how do you communicate to both?
Okay. Yeah, I think my approach is always to just over communicate. So I will make sure that I keep our clinic in the loop, and then I will make sure to keep our research team in the loop, with different paperwork that needs to be filled out, authorizations. They do send, like lab work over to the clinic. And so, yeah, I would say I'm just an over communicator by email to make sure everybody's in the loop and informed. Yeah.
Yeah, I think texting helps too. It's like quick answers, questions, and we can plan things on text and that kind of stuff.
Yeah. Great.
Next question that came in is, I have a 3-year-old with the normal mutation. There doesn't seem to be much that is needed for me to push the research forward with the new modulators. Is there still a role that I can play on the research side to help find a cure? I promise you that every research team in this room is salivating to have your 3-year-old come to them. There is still a lot of active research being done. The landscape has changed pretty dramatically, even since I started in CF 7 years ago. So things have changed and shifted, but there is still a huge need for people to step up and be brave and be volunteers. Everything from symptom management to genetic therapies like we've talked about to kind of more ancillary things like, mental health stuff and there's tons of research going on. If you are interested, I would say, reach out to your research team or your care team or whomever, even if they don't have a study for you right now. Just tell them, hey, I'm interested. Please keep me in mind, and you will end up on an Excel list somewhere. I promise. You will get calls as soon as they can find a spot for you. We are all actively still looking.
That kind of leads me into another thing that I wanted to bring up for everybody. It's like, how do you find out about opportunities, and then how do we as a care team and providers, how can we help parents and family members to know about what's out there?
Yeah, I wanted to add, so one of the things for me was I went to the CF Foundation's Clinical Trial Navigator, and that's how I first found out about the study. And then from there, I went to my son's CF clinic and said, hey, I found this study. What are your thoughts? And then they will go through the risks and the benefits with me, but ultimately it was my decision. So they didn't tell me either way what I should do. They said, here's your information, and then you can make that decision along with your husband. So yeah, I would encourage anyone who has CF that's in this room or families to check out that Clinical Trial Navigator. And just a little plug, there's also somebody who you can email. She's a Clinical Trial Navigator. That's her job, and you can email her if you have any questions about what's on that website.
Her name's Katie Howe.
Yeah. She's great.
Cambria, I actually have a question for you. What do you do when it's the day to go to, for research study, and Roland says to you, I don't want to go. I don't want to go. I'm not going today. I'm tired. I don't want to go. I'm going to play.
That's a great question. I will be honest, Roland's loved going. And he's just, again, and this is, every child has a different and unique personality, but Roland is very outgoing. So I haven't had that experience yet. And I hope I won't have it for a little while. But if he were to ever say that, I think I would probably validate his feelings, validate his concerns, and let him share how he's feeling, just because I think that's really important, as a parent. And then from there, we would obviously still have to go, and we would just make it as fun as possible, and then maybe do little lunch after or something fun afterwards. So that's what I would do if that had happened. It has not happened yet.
Yeah, as a dad of two, bribery is the way to do it. It's the only thing that works.
Yeah, I agree, Cambry, but that was just such a perfect answer, because I think that says a lot about how you are going to be as you go through the phases of being a parent, because I'm so happy for you that he's easy now, but there will be days when they're not, right? But you're establishing those, I think that's the best thing a family can do, is in the beginning, you are in control of everything, and you are, physically hands-on doing the care, you're advocating for your child, but then your role as he gets older is you become more of a coach of really trying to teach him to advocate for himself. But what I heard you saying is that I validate your feelings, but this is non-negotiable. You taking your Trikafta, or you're doing your treatments, is that's always a consistent thing, and just setting up those patterns over time will help him as he falls back later. So,
and then for Renee, how do you guys manage when you're really busy and you have a lot going on, and then you also have to go to your research visit and you also have to go to your care visit? How do you support Nick through that?
Well, I remember many times with the gene therapy, it wasn't easy on his body at all. And there were definitely times where he would be like, oh, man, I really don't want to continue putting my body through this. And the nice thing about research is the fact that you kind of have an end goal, hey, it's going to be over on this day. So you could look forward to that. But mostly, there were times where we'd lay in bed and we're like, well, this is not just for you. This can help you in the future. But imagine people like Roland who might be able to, the kids that have CF, it's for them as well. And we're able to see the bigger picture, and that yes, it sucks for these 3 months, but there's 30 more years that we have together, or he could live to 70 now because of this trial. The bigger picture, just playing that out for people really, really helps, and trying to just think above yourself and above those a couple of hours. And it's easy for me to say because I'm not going through it. And I'm just there to support him. But he definitely has that mindset where he's like, I'm just going to push through. I mean, I remember what I talked about, the last blood draw of the 4, where he wasn't able to get enough blood because he was so through everything. And he's like, I really just want to like get this because it's so important, like just pushing himself because he just sees that it's bigger than himself.
Hi. I haven't heard the sound of my voice in a while, and so I wanted to come to the mic. So I wear a few different hats. I am the mother of a child with CF. I am our family partner in Tucson who works in our pediatric clinic with our families. I'm also a mental health therapist. So what I'm about to say comes from all of those perspectives. One of the things that we work really hard on with my son, Micah, who is 12 years old, is instilling the value systems that we kind of indoctrinate with our value systems as a family as far as research, right? So coming from my college education and research I was involved in and understanding how important it is and how it doesn't just impact his health, right? It impacts the health of so many other people. So I find it really important that like whatever we're doing in regards to any research is explaining why we're doing it. And so Cambry, I'm super happy you don't have that happening yet where your absolutely adorable sounding little one is saying, no, I don't want to hang out with all the cool people. But there may come a time, right? And I think that being able to tie that back to like our family believes in helping helping other people get the care that they need, and you get to be a part of that, right? Like this is an opportunity and you get to be a part of that, and that is so exciting. So that is how I come about it with trying to explain things to Micah. We also are really we honor where he's at with it too. So if there were, he is a rock star now at blood draws. He was not always a rock star at blood draws. So we've come a long way, but I would have never put him in a few years ago, would have never put him in something where they were going to have to draw blood repeatedly because I'm like, that is out of his window of tolerance. And so doing what he's comfortable with. So he's been able to participate in not so much CF, but there's some days in Tucson that they have residents come and work with children and practice just doing exams with kids so they can learn how to talk to them and use developmentally appropriate language. So my kids, they also get paid for it. But my kids come in for that and they're super excited about that. But I'm like, you get to teach college students who are going to be doctors. And my kids are like, bet I'm there. So it's super cool. So both my non-CF and CF are going to do that. We've talked to him about the Stop Peds 360 study because I'm on the steering committee for that. But like, he's excited. He's like, so when am I starting that? So it's just, I think part of it is the education that we give them and the values that we give them. So that was the first thing that I want to say. I also want to really quickly say, was her name Rena? Renee? Renee. Okay, I don't know. I was making up names. So, Renee, I just want to say, you said right at the beginning, and I know all the family members were like, oh, girl, when you were like, I'm just a tiny little bit of a fiance. And we were all like, no, because you chose CF. And I just want to say, as a mom of a child with CF, thank you for choosing CF every day.
All right. So let's see. All right. So interestingly enough, Lila wrote down this question and it also came in here, but is there anything that we can do during visits to better help family and partners in support contexts and make sure they feel supported as they care for their loved ones? And related to that, how do you guys find the support you need to deal with the extra burden of having a loved one with CF?
Sure. Yeah, so in terms of the clinical trial, I think, so when I first met Lila, we did like some email exchange and then we did a video call. I think it was a video call. And I feel like my interaction with her, she's so friendly and open to any questions that I might have and very welcoming. And I definitely think that was one of the reasons why, we started considering this trial. I mean, along with many other reasons. But like I said, initially I spoke with her and then I declined the study. And then we continued to talk a little bit, and my husband and I had a change of heart. So I think in terms of like the research, I think just like providing a really welcoming and open space for patients with CF or families is just very, very, very important in providing that safe space to like answer any questions, or maybe like, I think sometimes the questions I have are really silly, and so, but not feeling judged by that. So I think for me, that's what was really helpful specifically for the clinical trial Roland's in.
For me, Nick had Armando to ask questions too, because that was his person. But Armando had a partner, Randy, who was also like doing the blood draws and was there. And it felt like I had a person to ask those silly questions to, because I didn't want to bother Armando, because I knew the study was super important. And Dr. Dozer, who was also like, I didn't want to ask the doctors questions. I wanted that to be like Nick's interaction. But it was so nice to like be able to just like sit on the couch and talk to Randy and ask those silly questions, because I mean, I've only known about CF for 5 years, like I said. So I had some like very basic questions that I wanted answered as well. Something that I think that would help in the future is that like post-study to be able to connect, and I don't know if this is allowed HIPAA-wise or like whatever, to be able to connect with, to be able to connect with the other people who have done the study, kind of like after a hard day of work, don't you want to like go get a beer with your coworkers and talk about like what happened? Like it'd be so nice to be able to connect with other people and kind of be like trauma dump on each other almost and like connect. Because like, I mean, I could tell my family and I could tell Nick's family and we could tell our friends and they're like, oh man, that sounds so hard. And it'd be cool to like bounce back and forth with somebody and connect with them on that level. And like, I mean, he was the first one in the US to do it, so I didn't have that connection. But like once it was over, I was like, man, I'd love to talk to the next people and see how they felt about it and like what they thought about it and everything. And just, I don't know. I think it would be great.
Yeah, I would say on that front, we as the research teams obviously can't tell anybody else who's also in the trial or anything to that effect, but there's nothing stopping you guys from creating, I don't know what the kids do these days, but like a Facebook group or something.
Yeah.
But yeah, preferably after the trial.
Yeah,
But
yeah.
but yeah, I mean, we can't do it, but there's nothing stopping the participants themselves from doing it.
Do you mind
Yeah.
if I ask,
Yeah.
Camp Renee, do you feel like the social workers have supported you as parents and as a partner? Not just the children or Nick?
I mean, Nick mostly just talks to his social worker. I've only met her a couple of times. But I don't know, like I kind of go through Nick of what boundaries he wants me to like step in on. Like, I'm not going to be like, hey, I really want to talk to your social worker so I could have that relationship as well. Like, we have a great relationship where if I have a question, he's going to ask her about it and like vice versa. So I don't feel like I need to do that at that point just because of the relationship me and Nick have.
So we don't interact with the social worker at the hospital where we do the clinical trial, but yeah, I found the social worker at our care center has been very helpful just throughout these past 3.5 years we've had a diagnosis.
How do you as a clinician involve social workers with research and resources and supporting family members and patients?
I'm trying to think of how. I don't think they're that involved with research, the social workers. They're heavily involved in our clinical teams, and that's just like part of our, we know that mental health concerns are higher in parents with children with chronic illnesses. So that's just like part of our routine screening and addressing the needs, especially in pediatrics. It's a lot more clearly defined that we need to do that. But yeah, I think having that support on the research side is something that would be really helpful. But our coordinators are, really well trained. I think, and that's part of why I think that some of those things like the relationship-centered care and the communication training for researchers is important for the RCs because they don't always get that kind of training. And you are facing patients for sometimes way more hours in the day than even just the clinical providers. And so I think that really takes a toll on the coordinators, and it so I think that's a need that we need to continue to work on improving with our research teams.
Yeah, I think like as research coordinators, working with social workers, involving them in research is something that we can do better too. And you guys can help our patients find resources. We can share them with you and involve you as well. And like personally, I always ask the social worker about like family dynamics of like research patients, if they know them ahead of time. And I try to get as much information as I can so that I can better serve the patient.
I think working with adults, it is a little bit different. We coordinate a lot. It really does take a village. We know our research team very well. We do a lot of activities together. We do a meeting every Wednesday where researchers are like, hey, this is what we're working on. This is the type of recruitment requirements that we're having. So that as a social worker, I'm meeting with a patient and they're, oh, you know, hey, I have a great study for you. If you're interested, we can bring the research coordinator down. So a lot of times we're kind of tag teaming a lot at our clinic and being able to have the opportunity, the flexibility of, hey, come down during clinic time and chat with them about this. Or, hey, is it all right if they reach out to you if you don't have time today to talk and interact? Yeah, I think we kind of have a smooth process with ours.
I also think it's important for, families and members and partners to know that social workers are not just for resources. We're here to also help you with the mental health aspect of it, the difficulties emotionally dealing with diagnosis, new studies, maybe possible difficulties with the studies and things like that.
That's where I think that integration between the clinical team and the research team is so important. Sometimes that's challenging.
So I'm going to combine two questions here because they're kind of similar. I guess we'll start here. How do you navigate research consent with a teen who doesn't want to participate, but their parents do? I'll say from our perspective, we kind of let the family guide that. They know their kid better than we do, and to what level of autonomy they want to let that, the teenager do it. Obviously, we're not going to hold him down and draw his blood or something, but if he, if they can work that out. I don't presume to know what's best for them. But in a similar vein, you can comment on that too, but for Renee specifically, what if you and Nick disagree about participating in a study? What would support look like then?
That's good. I don't know. I mean, a lot of the times we try to just be on the same page about it. I guess if we disagreed, I'm going to let him, him win because it's his body, his choice, his life of having to go to the doctor more often and all of that. I think, we're engaged, we're going to get married. I think it might look a lot different once we have kids because it's more of a time commitment. And that's probably when we'll start disagreeing. And, it would be like, yes, it's your choice, but how is this going to affect your, our family if, kid, the research study happens to be when the kid has graduation or, you never know what's going to happen in the future. I would say, it's ultimately his choice, but I think once we have a family, it will definitely be more a discussion back and forth and we'll think much longer about it. Right now, it's kind of like, hey, I'm interested. I'm like, cool, go for it. What can I do to support you?
Any questions from the audience? Yeah. Anybody else want to make a comment or any kind of question specifically?
I will say someone did mention that there is a forum called ResearchCon for people with CF and caregivers to connect regarding research and care. So that would be one way to talk to other participants and such.
I think for us as a research team too, and as a clinical team, just clear, direct communication, no surprises for family members and patients. It's how can we provide a really realistic perspective of what's going on and what you can expect when you're taking on these new challenges. Yeah. Anything else?
No, we have about 10 minutes. I'm not upset about ending a few minutes early. Would be fine too. But if anybody has any last comments, or if anybody up here has any last things they want, any last nuggets of wisdom to impart. Going once, going twice. All right, sold. Well, thanks everybody.